besides what's on the test? That's the most common question I get.
Is it going to be set up similar to the test that we've already taken?
Yes, it'll be same type of format for sure.
Okay.
Yeah, I don't like to change the format up too much because that's just cruel sometimes.
Yes.
But as you know, my tests, I don't think I'm that unfair on tests as far as how it's set up. Sometimes we get glitches. That does happen, but yeah.
And then you get blown up with emails at 9:30 at night by me.
That's okay. It's part of teaching. Nancy, you had a comment question?
Yeah, I don't know if you can see me when I go away, but the what's it called? Specialized techniques.
Okay.
Kind of, I missed a lot of questions on that quiz.
Okay. Do you have any specific questions? Well, let me jump to
Um, why why do we have to do PDOF to get the highest velocities?
That's a great question. So the reason we do PDOF, number one, it's for lab accreditation, for scanning lab accreditation, which is ICAO. They require that if you're doing aortic stenosis studies, it's required that you do PDOF for that. Otherwise, you actually can't get your accreditation. And their founding of that and the reasoning for that is because the PDOF goes into that the best window to see the jet without artifact or with the least amount of artifact with the most pure information is that right parasternal view. And so the PDOF transducer, if you've got your patient lying on their right side or left or right lateral decubitus, so you're scanning from the right side and you're aiming back down at the aortic valve, that's the best view to see the highest velocity. And so it's been proven that that's the most accurate way to do it. You could theoretically do it with a imaging transducer, but the transducer face is so big, it doesn't fit that space as well as a PDOF does. So PDOF is the gold standard for within our modality to be able to get the highest velocity. So that is required by ICAO.
So do we learn that at clinicals, or are we learning that at school?
Partly, yes. I mean, we kind of dabble in it here at the school. So if you haven't used the PDOF, I do want you to try it. So ask Tyler and Tammy. There should be a PDOF transducer for, if not all the systems, most of them should have it at least. I know for sure that the two new systems have it because I made sure we bought it because ICAO, that is a big accreditation thing that you have to have it. And they're cheap transducers. It's a simple CW transducer. But what you want to start with is you can start with trying to find the right parasternal. And I know that some of you have tried using PDOF. Try taking that transducer on a regular view. If you're taking like a 4-chamber view of the mitral valve, for example, you've got your imaging transducer, take the PDOF, put it in that same spot and see if you can get the same waveform with it. So that's the best way to practice it, is to use it on something that you already know and are familiar with. And then you can kind of, and all you're doing is just pointing in different directions. It's a blind transducer. You can't see a reference image. You're just pointing in and you're hoping, well, you're sort of hoping to get what you need to get. But the idea is that you're going to learn to recognize what the waveform looks like so that when you're moving it around and pointing it in certain directions, you can tell which vessel that you're on, or which valve, sorry, that you're on. Flashback to vascular, sorry. So you could do it from parasternal. So what Dopplers do we get from parasternal views? Parasternal might be an easy one to start with, just the concept of scanning it. So yeah, from here we get tricuspid valve. Okay, so we're looking for TR typically. You can also see the tricuspid inflow. So you just have to optimize your scale and baseline and so forth. So you can start with that. And the other side is the pulmonary. So between the pulmonary and the tricuspid, go to your parasternals, where you normally image from and just point the transducer in different directions. Um, let me really quickly run out and grab a PDOF transducer. I just want to show you a little bit because I noticed that when one of you guys were scanning, it was kind of backwards. So let me grab it real quick. I'll be right back. Hold on.
So how was everyone's weekend again?
Do you guys mind if I ask a few more questions about that exam?
Please do. I missed a lot on that one too.
Okay.
I want
Right ahead.
kind of an explanation on color and mode and that kind of stuff.
Yeah, that was
'Cause
where I was
that-
going next.
Because that one threw me off.
Yeah, I feel like we talk a lot about stuff in this class, but we never do it.
Yeah, yeah, very true.
So I don't like totally get it if I don't do it.
Okay, so here is PDOF transducer. So it's very simple transducer. That's the plug-in. Typically, it's just a little round connector that plugs in. It's got a single direction it can go. So if you're plugging this in, just lightly turn it until it seats in and just pushes into place. This one is off the 5500. It has a little collar that pulls back to release it. That's what the transducer itself looks like, okay? And so it's got that kind of curved or that angulated head to it. So this bar is movable, so I can twist it and turn it. Okay, this one's stuck. It's very hard, but you can twist it and turn it, and you basically use this to you kind of cradle it like this, okay, and you'll use your fingers to kind of twist it and turn it. But if this is the chest wall, it's going to sit like this. And if I'm down an apical, for example, I actually want it pointing up into the body that way. So that's kind of how you manipulate it. You can still anchor your hand, but this little crossbar, you can slide it up and down, and you can use it to pivot and to twist the transducer. So from the right parasternal, for example, up here, I want it pointing down towards the aorta that way. So this is the head, kind of pointing it in down towards that direction. So it'll be here, the patient's on the right side, and I'm kind of scanning up into there. If I'm down at like the apical views, I want it, the face of it's here. I want it pointing up this way. The other day, I think I was scanning, somebody had it done this way. The problem is then the transducer is pointing back that direction, kind of laterally. It's not hitting where it needs to. So wherever the body is, this is kind of, you're going to use that to manipulate and point between those spaces. So every system should have one. If it's not connected to the system directly, there should be one at least in the room. And if there's not, check with Tyler and see if we can find where it is. But yeah, we should have one for every system. But it is good practice, and the best way to practice is to start with what you already know for Dopplers instead of trying to hit that right parasternal view. Another good one to practice is, because it's a fairly easy spot to find, is that the jugular notch. Okay, so just again, a little bit of gel goes right in there, and you can kind of point down. This actually angulates and gets that descending thoracic aorta a little bit better than your imaging transducer because it's so tiny. The space of it is. So again, you're not going to see a picture, but what you can do is just kind of point down and find your waveform. And again, if I'm going for descending from this position, the waveform is going to be below baseline. If I go to ascending and move it over to this side, it's going to be coming up towards my transducer. As a note, from the right parasternal view, you're going to be higher than your regular parasternal view, but just on probably about a centimeter or so away from the sternum on the right side. Your waveform is going to be coming up towards the top. It's going to be upright. So it'll look like you're just your regular aortic waveform, but it's going to be up instead of down, and you won't have a picture to show it. Does that help?
Yeah, it does. Thanks. And you say then for a lab to be accredited, it uses that for AS.
Yes, that's required for AS studies, correct.
And then can you talk more, a little bit more about color and mode?
Sure. So the one that we use it most commonly with is propagation velocity. And having said that, there's not a lot of labs that do propagation velocity. So don't be surprised if they don't. It's not a big deal. It's kind of back when I was scanning, nobody ever did it. Just a couple of people, crazy people like me would do it just because I get bored and want to do something different. Um, but that may be more common now. But what it is becoming more common with now is using it for things like regurgitations. So if I'm looking at the aorta, for example, and parasternal long axis, and we pass it through there, we can get an idea when the regurgitation is happening. I think one of the more useful ones is with mitral valve prolapse. So putting it through the tips of your mitral valve like you usually would, but with color Doppler. So to use color M mode, you have to stick your color Doppler on first and then pass your cursor line for M mode through it and then run the M mode. Most systems don't let you go into M mode and then turn on color. So you got to turn color on first, pass it through, and then you'll see it. But it's helpful to see the timing of when regurgitations are happening. Theoretically, you could do a vena contracta with it if you're lined up properly, but only do that if your doctor knows what you're doing. Because if you're just randomly put it out there and the doctor's not familiar with that, they're going to call you crazy, and it is what it is. So just make sure they understand what you're doing. But theoretically, I could do that. I could also use it for, you could use M mode by itself with or without color Doppler to do the sniff test. I mean, there's all kinds of good uses of M mode if you wanted to.
So I guess what I'm confused about, that you say that we mostly use it for propagation velocity, but the question was, if you're using color M mode, what parameters wouldn't be feasible to measure?
Right. So when I say propagation velocity, that's what they call it. It's not an actual velocity, it's a slope. So what they're looking for is distance over time. That velocity of the acceleration distance over time, meaning how fast does it go towards the LV apex from that 4-chamber view. It's probably poor choice of terminology, I think, more than anything, because it doesn't actually measure velocity. All color Doppler does is give us a mean velocity, kind of a generalized. It can't give us a peak velocity.
But so it gives us a mean velocity, but it doesn't,
But it's not measurable.
it's not measurable. Okay.
So on M mode, you're pretty much stuck to, you can measure slopes, which is just a factor of distance over time. And so you can measure distance really well vertically, and you can measure time horizontally. And the combo of those is a slope, but that's all we can measure on M mode.
Okay, thank you. I
Yeah. I
think
know
that's
that
where I got
the
really
name is a little bit
confused.
deceiving. I get that. If
Could
it was my
you
choice, I wouldn't have named it that.
could you help me with understanding VVI? Because I'm still a little lost on that, to be completely honest.
Okay, so VVI is specifically velocity vector imaging. So that is a form of speckle tracking technology. So with strain imaging, so let's start there. So strain imaging is the idea of looking at how stiff a tissue is. And when we, like, again, if you're palpating something, if I'm palpating the back of my hand, I can feel tendons, okay, and I can feel soft spots in between. I know that those are gaps where there's tissue between the bones. So the tendons and the bones are a little bit more hard and rigid. So we palpate that. And what we're looking for when we palpate that, just cognitively, is when I press on that, it's stiffer. Okay, that area that has bone underneath it is stiffer. The area that doesn't is softer. Okay, so think of strain imaging as just that. If we're looking at the areas that are stiffer compared to those that are softer. And in strain imaging, it's all relative to everything else that we're imaging at the same time. So, you know, it depends on what tissue type that you're imaging and stuff like that.
And do we only
The
use this
early,
for tissue and nothing else, right?
so yes, it's a tissue. I mean, yes and no, because the newer technologies, we actually have velocity vector imaging for flow now as well. There's flow dynamics and stuff. So there are untapped abilities. It's a pretty new technology still, relatively speaking. I mean, it's been out for about 10 or 15 years, but in our industry, that's new. The fact is that the uptake of it in the use in clinical setting has not been very fast. They take a long time before people widely start using it. People in teaching hospitals have been using stuff like this for 15, 20 years. Okay, because that's where they come up with this kind of stuff and then they develop it. And so in the tissue, what we're doing is, so first of all, it started with Doppler-based strains. So you could see, the tissue moving towards and away from the baseline. They could use those maps and extrapolate some data. But what's the one thing that we know about color Doppler that's a major pitfall, major problem? With any
It's
Doppler.
angle dependent.
Angle dependent, absolutely. So the areas where it's close to 90 degrees, we can't get a lot of information from that because it's angle dependent. And what do we know from an angulation standpoint as far as the accuracy of your data? So 0 degrees is what?
Is there like true angle?
Okay, that's our ideal angle. 180 or 180 degrees is also our ideal angle. 90 degrees is our poorest angle, right? But everywhere in between that, we can pick up data, but is it the same data as the 0 degrees? No.
Tammy was very
So-
much stressing that we get our proper true angle, otherwise it's completely worthless data.
Yeah, absolutely, and that's absolutely correct. Yes. So do what you have to do. And in echo, what we do to get that true 0 degree angle is we need to find the window that has that perspective. So we're placing our transducer at 0 degrees. We don't really use angle correct in echo, even though we use it in vascular. We want to line up, because we have the ability to line up at 0 degrees, we do that. That's a preferred method. In fact, I've had students that have actually tried to use angle correct, not by my recommendations, but then they got in trouble from the clinical side. It's like, what the crap are you doing? So yeah, line it up as best you can. That's going to give you the best information. But in strain imaging, it's the same thing. And if we get off axis and we're at say 60 degrees, our information is going to be poor. Okay, from a data analytics standpoint. So the next generation of that was speckle tracking. So that's identifying the bits of speckle and seeing where they move over time. Okay. What do we know about the contraction of the heart? So if this is the apex and this is the base, does it simply move to and from that way? Okay, that's
It's like wringing out a rag.
It's like wringing a rag, exactly. So this direction from apex to base is longitudinal strain. Okay. And then we have a circumferential, which turns, and then a radial, which is the thickening of the muscle. So there's 3 different ways that the muscle contracts. Okay, from a 2-dimensional standpoint, if I got a pixel here and it moves towards the base a little bit, we're tracking how fast that moves and how far it moves. If it doesn't move very far, that means that the tissue is stiffer. If it moves a long ways, that means that there's a lot of flexibility to that. There's a lot softer tissue. It's less strain is involved in that. If and how fast that moves is the strain rate. At what how fast does that deformation happen? So you're deforming the pixels or the tissue, and you're moving at a certain distance at a certain rate. That's what we look at. To make it a little bit more complex, because we know that it's also ringing, and I've got my single slice, if it's ringing, and my pixel that's say right here is there, okay, as the heart squeezes, it goes out of that plane, right? So from a 3-dimensional standpoint, we actually lose the pixels out of our plane of imaging a little bit. So you could use 3D strain imaging would actually help rectify that as well. But that's what we're looking at, is how stiff, and that gives us an idea of how stiff the tissue is. And we know that the stiffer it is, the more diastolic dysfunction there is. Okay, so that's how our correlation happens with strain imaging. Where do we use it clinically? Most, from a broad perspective, is in cancer treatment. So if people are doing chemotherapy, we will often look at the heart and use strain imaging to see how that's affecting, how the dosing of that chemotherapy is affecting that person's heart. And so that's where it's used the most, and there's certain characteristics that you're going to see. What other applications could we have? Remember, it's a new technology, so they're still finding new ways to apply it. That happens to be the one that's been the most widely used. But it could be used for looking at amyloidosis. It could be used for looking at any other type of hemochromatosis, sarcoidosis. I mean, just anything that's causing diastolic dysfunction could be applied to it. Now, there's other types of strain imaging in the clinical world that's not cardiac. The general imaging, for example, they actually shoot out, that's that RFI technology, acoustic radiation, hold on, acoustic radiation force impulse imaging. And that's basically the transducer sends out a pulse that pushes the tissue. And then there's shear waves that go off the tissue in a perpendicular direction to what the beam is. And what the system does is actually measures how fast that happens. And that's how they use it in like liver strain and stuff like that. I would expect that you're going to see more and more of that type of technology coming out throughout the body generally with ultrasound. But that's the concept of strain, is that we're looking at the stiffness of the tissue. How does it relate to the heart? We're looking at how fast that deformation changes. We're looking at how stiff the tissue is, which gives us data about diastolic dysfunction in particular, but it could have other implications like systole as well. If we match multiple wall segments, we can compare those and see which one's contracting at what times, how much it's contracting, how forcefully. So to your question on the VVI is a Siemens specific technology where they're tracking those pixels, but they're adding a vector analysis to that as well, where it actually shows what direction and how strongly that the tissue is moving. So the bigger the arrows are, the more soft the tissue is, the more flexible or elastic the tissue is. The less that they move, the more stiff the tissue is. Okay. And that's not angle dependent, and that's important because then I can look at various clips. I can look at a short axis. I can look at various things and see, how that's working or not working. Does that help? Sorry, I could go on for hours on that. That technology, I would expect to see a lot of use in the future. It's got a huge amount of data that you can get from a single clip. The nice thing is you can apply it to clips that you've already acquired. You can do it on offline systems, meaning I can take it to the computer PAC system that has software on it to do that, or you can do it on the system. Either way, so there's a different ways of applying that, but there's a ton of information can be determined from that. And while we're using it in cancer therapy right now, and amyloidosis, there's going to be a lot of other applications of that coming out. Pretty cool. So that's strain. As far as my testing on strain, it's not going to be that detailed, but it's going to be fairly lightly touched. But I would expect to start seeing it on registry exams now as well, the concept of strain at least. Uh-huh.
Could you go over for like what we need for like aortic valve area and that kind of thing? I still have trouble like remembering what exact measurements we need and where they plug into the equations.
Good. So let's take the first concept. So when we look at aortic valve area, what is the most important thing that we're looking at? What are we trying to determine that we don't know?
Whether they have like aortic stenosis or not.
Okay, so stenosis is part of that, but what physical characteristic of that are we wanting to determine? If we could get a measurement of something, what is it?
How much the valve opens.
Yeah, so when it's open, how big is the hole? How big is the output hole that's there? Because that is our restriction. If it gets tight, the tighter it gets, the faster that jet goes, the more pathologic issues and stuff that we have. So what we're really interested in is the area of the valve. That's why it's called the AVA, or the aortic valve area. Mitral valve is going to be the MVA, or mitral valve area. That's what we want to determine. Now, on the aortic valve in particular, we use the continuity equation mostly. Go ahead, Mike.
For aortic valve, normal area, just making sure I got these numbers right, is like 3 to 4, right? And then for severe, it's 1. And then for mitral valve, what is it? Because I forget those specific numbers. Is it
I
like
was-
0.75 for severe?
I believe so. I
Okay.
word off the top of my head. I don't have to use it on a daily basis anymore.
Because I remember 0.75 being severe for something. I just couldn't remember for the life of me which one,
Yeah,
which
I
valve
believe
it
that's
was.
it. Um, let's see what
And then
page
what's
it
the normal mitral valve area?
Let's go to, let's get bigger on that. Let's go to the mitral valve.
I think normal is the 4 to 5 centimeters squared based off of Tammy's PowerPoint.
4 to 5. Okay, because I
Yeah.
remember in like the hemodynamics chapter, I think it was like 3.5.
Yeah, yep.
Like we've
It
been
was,
given
there's a
so
little
many
bit.
freaking different ones. I'm just constantly lost.
Yeah, I think you're right though, Michael. We were given that 3.5.
Yeah, I get, yeah, so that's the hard part is that these charts do change a little bit over time. Just trying to find,
And Michael,
Yeah,
just like aortic
3.1 in the hemodynamics chapter for
Yeah.
cross-sectional area.
yeah, and you'll be less concerned about that as much as, knowing the severe is definitely one that you want to go into the scanning room knowing, because that, when you start to exceed that or get underneath that number, that's when things start to change as far as how they treat the patient.
Yeah.
The follow-up stuff, if it's getting, if it's a ways away from that, but somewhere in the mild to moderate, you'll have typically charts on the wall in your lab that you're scanning with that, you can go to those charts and you can look it up. You can use a textbook, but we often had like all of our cabinetry around our office. We always had we had charts of numbers.
I'm
On
more than
every
happy to have a cheat sheet with me.
yeah, when you're scanning, you will. I mean, you may not have it in the room, but you'll have it there. But the number you want to know is a cutoff when you're doing practical echo versus when you're going into the room.
Yeah. That's why I really want to know what the severe is for mitral, because I
Right.
know it's important.
well,
only
so
thing
Michael,
is I can't
you
find
know our mitral valve PowerPoint that we have?
Under
Um,
which
for
class?
Tammy. For Tammy.
For Tammy, okay.
So she gave us one that said a severe cutoff would be less than 1 centimeter squared, which would be the same as aortic valve.
Yeah, that's kind of what I would go off of, but I think what you're saying though, Mike, was accurate as far as being 0.75 or less. Let me just go to it in ASD. Just to give you a number.
Numbers are good numbers.
There is a very good references in echocardiographer pocketbook. A new edition, you can open 249, or I can make a picture, Marco, for you and send you. And it's kind of every chapter has this information, which is good to review.
249, you said?
Yeah, it's a new one.
Which book is that?
It's
Pocketbook.
pocket.
Oh, pocketbook. Okay.
Yeah.
Yeah, I guess it does say under 1. Where was I taking the 0.75 being? Is that critical maybe instead of severe that I'm thinking?
It could be. Yeah,
But
that's
for what?
definitely an advanced level of it.
But is that for the aortic valve or the mitral valve, or is it for both now?
So this is for mitral.
I thought they had the mitral and the aortic the same, so you didn't have to remember additional numbers. Trying to find where ASD has it. So here's the complicated part. When I was scanning, we used to have one number for everybody. Now the charts have really started to narrow down between genders, between nationalities.
Yeah.
They're trying to get more specific. So the charts are getting a lot more voluminous. They've got a ton more data than they used to have.
So should I assume just severe for both is just 1 and then critical would be 0.75 for
Yeah, but that's gonna
both
bug me now.
or what?
So
My caveman brain needs specific numbers to remember.
Have you found this chart, Michael?
Yeah, I found it. So it definitely says for severe, it does say under 1.
yeah,
So that is definitely that. I'm just
we go for that for now,
I
but
know 0.75 was somewhere in this. I just thinking I don't know if I'm pretty sure it's a critical number, but I don't know for what valve now.
Yeah.
yeah,
And
under,
for aortic one, if you want to check, it's page 201.
201. Okay, I will.
Yeah. It's a very nice chart in the ACE recommendation. So
Yeah, I quite like this.
yeah, that pocketbook is super handy for this kind of stuff because you'll have the charts in that. It should be in conjunction with ASU standards.
Yeah, okay, so the numbers in this pocketbook are just the same for both of the valves. So that's
Yeah.
that's good.
And honestly, they do that because could they have a more specific one? I'm sure they could, but it's nice to make numbers that have an easy cutoff so that you can remember. Because for text to remember that, like I say, when you remember that going into the room, as soon as you now get below 1, yes, you're going to bring out the charts and you're going to look at that more particularly, and we're going to put
But you
as
can
much
solidly
data.
say it's severe. You can make a
Yeah.
definitive answer instead of it's kind of moderately severe,
Yeah, like
maybe
below
moderate
that, about
plus.
45%. Yeah,
Jesus
yeah,
Christ. So wishy-washy.
a little bit,
Which
a
is
little
like,
bit.
it gives you wiggle room because patients aren't the same, and I get that, but
Yeah,
decisions, make them.
yeah, that
Come on,
definitely helps.
be
Did you have
decisive.
I'm still looking at this, but Irina, did you have a comment as well? Nope, we're good.
She's muted, but she's trying to talk.
what was the question? I missed it. So
Oh, I thought you raised your hand.
no.
Okay, so while we're talking about numbers, what methods do we have? So let's go back to aortic valve. So what is the most common way to measure aortic valve stenosis?
It would be the continuity equation, correct? So you can get aortic valve area.
Yes, and so to answer Mike's question, when you go in the room, what do you have to get?
The pulsed wave LVOT and the continuous wave flow through the valve.
And the LVOT diameter.
Right.
Yes. Yes.
Well, sorry, I thought we were just talking about that. So
Yes, so those are what we need to get. That's great.
Sorry, could you
I'll
run
go
through
back.
that list one more time for me?
So 3 things. So remember 3 things when you go in the room that you have to get. First one that you're going to obtain, just because it's the order that we scan in, is the diameter of the LVOT. Okay. The second thing we need to obtain is the pulse wave Doppler of the LVOT at the same area that we took the measurement at, which is just before the valve. Okay, so let's stop there before we go any farther. What did those 2 pieces of information tell me?
stroke volume.
That's stroke volume through the LVOT. So that's important to realize that in itself is at one location. Okay, what piece of information then do we get from the aortic valve, which is a different location, even though it's millimeters away?
That's the
Velocity.
one I'm struggling with. Is it, okay. So
We get
it's,
peak velocity.
CW peak velocity?
Yes.
Okay.
So think of it
It's
this
still a
way.
VTI though.
Yeah, yes, and you'll do a VTI. We take typically a velocity just to see if we're getting near that stenosis range, but properly done, you're going to do a VTI. Okay, so your VTI times the cross-sectional area gives you the stroke volume.
Can you give me a number for that range that we're getting into stenosis? I like numbers.
So for getting into stenosis, so if I'm looking at velocity, sort of a rough, if I get over 2 meters per second on my CW through the aortic valve, we're in stenotic range. We're past normal. Okay, so once it goes beyond 2, you're past normal. If you're like 1.7, 1.8, that would be an elevated velocity, but not a high velocity. Okay, that could be caused because of a hyperdynamic heart. That could be caused by a lot of fluid that's in the heart, the Starling's law. So those types of things could affect a minor increase in velocities. What's a normal velocity is probably around 1.5 to 1.5. Like 1.25 to 1.5 is like totally normal range. If it gets below like 0.8, for example, that's a very low output, a very low velocity, and there's probably some EF problems going on big time. So you may see that drop, but when it goes up, we see the elevated, and then we get into stenotic above 2. Okay, that's where it becomes mild or moderate. And then when we get to the stenosis, I think it's like 4 to get into severe. 4 meters per second. So that's pretty fast. Okay. So it's going to be more than double what you're used to seeing. So you should not be surprised when you see screaming velocities, but you're also not going to be surprised because when you scanned it and you're looking at the valve, you see probably a ton of calcifications and you're going to have a hard time seeing the valve open. So you're going to already have some visual clues that there's something going on before you get to quantifying it. Okay. So what's again important to realize is when I'm doing the LVOT, I'm looking at one distinct area and I'm comparing to a separate distinct area. And then we have to use algebra to figure it out. So if I put this in the mathematical realm and we could complete the formula, what we'd be saying is that the cross-sectional area of the LVOT plus or times the VTI of that number equals if I was able to measure the cross-sectional area of the aortic valve times the VTI of the flow in that area. Those numbers would be equal in a perfect world. What we don't know is what that area is, so we can use algebra to move the VTI from the aortic valve and divide the other side by that. That gives us our X, which is the aortic valve area.
And that makes sense, and I can do that, but I'm assuming in the field that our machine does that for us.
Yes, it does.
Okay.
It's actually a
Great
pretty
news.
simple measurement to do. If you
Yeah,
have
no,
to.
it's just X equals this. Figure it out.
Yep.
Not very hard.
And Scott, to clarify, to go along with that, according to the equation, if the stroke volume would be indirectly or inversely related to the highest velocity as well, correct? Because I think that's how it's set up, is cross-sectional area times the LVOT over the VTI of the AS.
Yeah, so as my AS goes up, yeah, that's gonna, yeah. So the aortic valve area is gonna be that one. Good. So does that help, Mike? Okay.
Yeah, no, that definitely helped. Those were two things that I was just like, hello, I don't know why, but I can't think of this properly.
So when you go to do an aortic valve exam, if I do it that generically, what do I want to know about the aortic valve?
Well, you want to know how
Note
well
this one.
you want to know how well it opens, how well it closes, if it like prolapses, anything like that, if there's calcifications, the area of it, how much flow we're getting out of it, how much flow is coming into it, blah 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 blah.
Yeah, so you want to know if there's stenosis and or regurgitation. You want to know, like you say, the 2D information. So anything you can do to show me the physical valve itself, golden. That's what we want to see. And then that Doppler information is vitally important. So
Make
if you're
sure it's
doing
3
an aortic valve
leaflets.
study, yeah, if you're doing an aortic valve study, it's really important that you do the continuity equation. So you don't necessarily have to get me a VTI of the flow through the aortic valve. On a normal heart that looks like it's opening and closing fine, we're okay with doing just a peak velocity on that one measurement. But technically speaking, we would do a VTI.
Okay.
So with the aortic valve stenosis, we want to know the aortic valve area, but what other pieces of information help to quantify how bad that is?
The vena contracta.
Okay, that's for regurgitation, yes. On a stenosis.
How about stenosis is? We'd look at the velocity, we would look at the area that we have, whether it's within
So
normal range
think
or
about the
not.
measurement you're doing.
Ejection
If we're doing
fraction?
so what measurement do we do on a VTI of an LVOT? I just told you VTI.
Yeah, we
The
just
pressure
chose
gradient.
VTI.
So yes, so when I take a VTI, what parameters, what measurements does it provide me? So I get centimeters, that's the VTI,
Mean.
that's the actual distance tracking over the waveform. That's one peak. What else will it give us?
Yeah, the mean, like Nancy was saying, the mean peak gradient or the pressure
Velocity.
gradient and
Yes.
max.
So when we're doing aortic valve area, the area is important. Your peak velocity is important. Your mean velocity is important, and your mean pressure gradient is important. Those are 4 parameters that they'll use to gauge the severity of it. Okay, so just the peak velocity in itself can be problematic, because if we have overgain, I mean, even overgaining with VTI is going to throw it off, but it's easy to get an erroneous measurement of a peak velocity because of overgaining or little spikes of stuff that come through there that you might, if you rely on your ultrasound system to always do the measurements for you, sometimes it picks those things up as the peak velocity when it's not actually the peak velocity. So it's really important that you correct it to make sure that it's accurate to what it is, and make sure that your gain is set appropriately so that you're not over or under measuring what it is. Good. Nancy, go ahead.
So now including the PDOF into this stenosis, we get the waveform. How do we know we're through the right place? And then when we get the waveform, do we VTI it?
Yes. So you would do the same measurements that you would do on the regular aortic flow that you got with your imaging transducer. So that's correct. So we VTI it. So that gives us our mean velocities, our mean pressure gradients, our peak pressure gradients, our peak velocities, etc. So that's all the same. That's a great question, Nona, and you emailed me this as well, and I think your discussions with Tammy. There was the question about what happens if we get a tricuspid, or aortic stenosis and a mitral regurgitation, because they look similar to each other. And the answer to that is really that it would have to pass, the continuous wave would have to pass through both to have them on the exact same waveform. And they are overwritten in the same physical location on the strip. So technically, you're not actually probably going to have both of them on the strip, but approaching that view, it's going to look very similar. And the only distinction is, number one, the shape of it. Remember that the regurgitations are more parabolic, but they can get that V shape-ish, which is more like the aortic valve. Think back to your clue. So in EKG, we talked about when somebody's having like VTAC, okay? If they're in VTAC, yet your patient's talking to you normally and doesn't have symptoms, we're not concerned that it's actually VTAC, right? So with this is the same concept, is you're already going to have some clues. It's what is the likelihood of having somebody with a severe aortic stenosis and a severe mitral regurgitation? Okay, probably not quite. I mean, is it possible? Yes. But what I'm saying is you're going to have clues going into it how severe something really is. And then when your Doppler is going through it, you would have to be passing through those exact same time. And if it's overriding the same location, your MR is going to override it because it takes up the space of the IVRT and the IVCT. So seeing that there is an IVCT and IVRT is a distinguishing factor between a mitral regurgitation and an aortic stenosis. So from the end of the A wave to the beginning of the aortic flow, or from the end of the aortic flow to the beginning of the E wave. I said A wave on the first one, right?
Scott, would it be possible to show us like a picture and see it visually? Because it's hard for me to kind of understand it. Thank you.
Let me jump to.
I could try and draw it.
Yeah, go ahead and draw it while I look on. I'm going to see if I can find a picture of an actual waveform.
Okay, here's the baseline, and here's the E and the A. And you have the IVRT right here, because here's the aortic.
I think
Well,
that's IVCT.
Yeah. No, that's where you're right, because we measure between here and then here is the IVRT, right?
Yes.
Yeah.
Okay, so this is the IVCT. So if you get the mitral regurgitation, it's going to come down like this. But
Yes.
this one's going to be a little brighter
Yes.
sometimes.
Usually
you'll
it will be
still-
brighter because it's a more intense waveform.
But the MR is going to start right here.
Yes.
This is the MR. And then the AS will be brighter and will start here.
Correct. That's right.
So it's all about where it starts and when it stops, and then if there's a brighter waveform within a waveform.
Yeah. The one
Yeah, but
that
the likelihood of getting
Tammy-
both of them together are not as likely. Because again, your waveform, your cursor would have to be passing through both of those and when we're talking aortic stenosis, it's hard enough to get an aortic stenosis at its peak velocity because that hole is getting tinier and tinier.
the one Tammy showed me, one she showed me was like this, and one she showed me was very, very hard to see. And it was barely, but it was that timing.
Yes, the timing is the distinguishing factor for sure. So let me share my screen here and I'll just show you this. So just for a basic setup, so this is the basic. So here is your E wave and your A wave. Okay, here's your aortic valve jet. Okay, we're 1, 2, 3, 4, 5, almost 6 meters per second. Okay, so that's pretty significant if that's what it actually is. That measurement is off. I'm not sure I like that. I mean, yes, you get some valve clicks and stuff like this, but you have your IVCT, which is the end of the A wave, the beginning of the aortic jet, from the end of the aortic jet to there. I think what I'm saying is that I think the jet's actually right here. I don't like that at all, actually, because that actually
It does say errors to avoid when measuring the valve, maybe.
Yeah.
Yeah, it's just a good example of that.
That's a good point. I really don't like that one. All right, that looks like it's a fetal heart. Let's not do that yet. Okay, here's a regurgitation. So the regurgitation, as you can see, there is no space after the A wave, and there is no space once you see that valve click, which is that saturation at the beginning there. So it goes from the beginning of it to the end of that timing. So the aortic definitely has a different thing there. So this would be a normal flow, mitral inflow, aortic outflow, the space between. So that's our distinguishing factor. I was trying to find images that have both of them together.
That's why I asked you for images, because I couldn't find any.
I mean, I get the concept, and if you were to overlap them, yes, I just think that the likelihood of actually getting them to overlap is not that likely. Is it possible? Sure. And this is too small to even see what's going on. So here's the other thing is that when you're looking at that jet and you're trying to determine if you got the super tiny mitral inflow, if you're just looking at the timing, you can decrease your scale, your PRF, so that you can see that timing a little bit more clearly. You need to see the E wave and A wave to be able to make that determination. If it's super bright or if it's super tiny like this one is, that's going to be hard to determine for sure. Yeah, I just haven't been able to find any good examples of that.
Tammy has a picture, 2 pictures of it on her phone if you want to ask her on Monday.
Oh, does she have an actual example of it?
She has 2 pictures on her phone.
Did
Yeah,
she post it in this?
You might get some good ones just being in the pediatric lab. They
I
do
don't think she's posted them yet, but she said she was going to, but I mean, I kind of feel we were lucky to get her to post anything.
So here is, so if you can see this waveform here, you can see that there's a hazier line here, and there's a more intense signal in the middle. Okay, so you do get that appearance sometimes. But again, you have to pay attention to your IVRT and IVCT. I think this is all aortic flow here, and this is actually LVOT flow inside of that. So just because you see that envelope in an envelope doesn't mean it's MR and AS together. You still have to look at the timing of it. Here's another example where you see an intense waveform in the middle here and a little bit fainter one there. We're hitting close to 4 meters per second there. And I'd say that they're probably over measuring this anyway and over gained on that. You can see this person's probably in a fib as well because this E and A wave, there's no A wave there. So they're probably in a fib, I think. Yeah, anyway. Oop, just clicked into the thing. So the key is the IVRT and IVCT.
Yeah, thank you. Concept is clear. Yeah.
So it's a little unrelated to midterms, but I wanted to talk to you really quickly about our final for lab.
Okay.
Are we all going to be like rotating through one machine?
You'll have to ask Tyler and Tammy that because they're doing it. I told him how I do it. And then because I've heard some of the students say that they're doing things a little bit different. So you'll have to ask them on the exact nature of how they're going to apply that. It's really going to be up to Tyler, and Tammy's there to help them.
Okay.
But I would ask them that. If it's me, what I usually do is I usually have the same system. I usually have a decent patient. But I also had a 15-minute time frame, and I had my expectations for that. I think he might be doing things a little bit differently. It sounded, I mean, correct me if I'm wrong, because one of you guys told me that they're going to have you scan a whole case. Is that right? I don't know.
To the
I'm
best
hearing
of our knowledge, but also something like, hey, we have this kind of disease that we're looking for. What do we need?
yes. So
I've been told it's kind of both, but it's been kind of wishy-washy.
Incorporate that. So they're going to incorporate that for sure, but they're also going to, it sounds like they're also going to have you do some more scanning. So you really will have to talk to Tyler and them just to make sure that you know what he's expecting. I don't know the question if they're going to switch systems or not. I personally don't. I personally have you, I have a good system, a good patient to scan. It's the same patient to scan, so it's all equal, but that's what I do. What he does is going to be up to them.
Yeah, that's kind of why I was asking, because a couple of students were, we were talking about it, and it only seems for consistency and fairness to everyone to have us all scan our final on the same machine.
Yeah, I mean, that's the way I do mine, but they can do it differently as long as when they're grading it, they're taking into consideration the differences, which I think they would.
Okay, yeah.
Yeah, but definitely explore that more. The only thing that I've heard is from you guys. So I don't really know what the true story is from what he's actually going to do. But ask him. I mean, it'd be nice to know probably in the next couple of weeks for sure exactly, I mean, yes, I'm vague when I do mine because I kind of tell you, but I also tell you that I am going to have the same system. I am going to have the same, easy patient to scan. I don't want that to be the determining factor. If you have different patients, obviously there can be different things going on with breathing, with the patient's size. I mean, just lots of things. So I don't personally put that as a testing point.
Okay, yeah, I'll be sure to touch base with him about it.
Yep. Yeah, clarity's good. Don't be surprised if they don't give you all the information, because part of the testing process is we do want you to be able to critically think. But just as far, I think it's reasonable to ask the logistics setup of it. Teachers are quirky, aren't they? Good. So there will be probably some stuff on just a minor amount on contrast. So tell me about contrast.
It's used to enhance our images to make sure that we can properly identify things.
Okay, so echo enhancing agents.
It's also checked for VSDs. That way we can see whether things are flowing in the opposite direction or not good directions through shunts, or if we have like an AV. Is it AVM or AMV?
AMV, it's arterial
AM,
venous.
yeah, yeah.
AVM, sorry, AVM, so arterial venous
See, now you
malformation.
know I always which one it is. Yeah. Okay. Yeah, AMVs to make sure that we don't have any shunts in the pulmonary system. AVMs. Now I'm gonna be confused the whole time. God damn it.
Have them. I don't know. Make up some acronym that you can remember.
Always very macho, or some stupid
There you
like
go,
that.
Nacho Libre.
It's arteries and veins that don't work right. AVM, they malfunction.
So the vessels go first, arteriovenous malformation.
Makes sense. We could actually use the actual definition too. That would work.
And that's what I did. That's what I did, but you know, whatever. and then we get terms like VTI and TBI, same thing.
Freaking hate that in the book when it's like a
Sometimes it would be
TBI.
nice there's more consistency in the industry, but that could be asking a lot. Okay, so what type of substance makes up the inside of the bubble?
Are we talking about agitated saline or other type of bubbles?
Yes.
Because if it's the other type, it's
Fluorocarbon.
fluorocarbon. If I see it in words, I'll know what it is. I just can't say it right.
Right. So we know that it's a gas that is that doesn't react with tissues. That's good. Where does that gas go once it ruptures?
Through the lungs, and we go.
It's breathed out. Yep. And what's the other part of it? The shell made of?
The lipid bilayer.
Okay, which one's bigger? The LVO type of, like the definities are bigger or smaller than the agitated saline bubble?
Definities are smaller.
Okay, so definities in that are smaller.
Aren't they also more uniform?
Saline is bigger. Say that again, Mike.
Aren't they also more uniform size?
Yeah.
Yeah.
They are.
And I learned from Ella last night that the lipid bilayer is processed by the liver, and that's how that goes out of the way.
Yes, and
so
and
props to Ella.
Reabsorbed into the body. I happen to have a nifty little example of a for agitated saline. So this is a three-way stopcock. Okay, so on this, it's got a little directional valve type thing that you can move to different positions. So what you do is you block it off, and then you'll have your stuff already drawn up. I gotta get some air in it. And then so you'll have some saline in here and you'll have some air in there. And then all you do is you're gonna go back and forth like this, and that's what agitates it. Okay, when you're ready to fire, then we turn it and go and squeeze it in.
Are we ever gonna be doing that?
Yes, you could. Yeah.
Yeah, I gotta play with bubbles.
That's why you took the IV therapy classes to learn how to set up the IV. But this is just a simple setup. So it's three-way stopcock. You'll have saline in one with some air, a certain amount. It's usually, I think it's usually like 10 C or probably about 6 or 7 cc's, and then a couple of cc's of air. And then you're just agitating it back and forth, just shaking it up. Okay, and then you open it and then you inject it in. You know, you're not just gonna like boom push it in. You're gonna press it in, at a decent rate, but not super fast. And then that's going to go through. So so you mentioned things like shunts. So which type of solution do we use for shunts versus existing wall motion?
Isn't it saline?
Agitated saline. Yep. So any shunting, this setup. The other one, you just put your Definity in the vial and you just inject it directly into an IV. So
Scott, I was going to ask you, how common is it for us to have to actually set up our own IVs? Or are we going to be going into patients' rooms that typically already have an IV started?
Yeah, if you're in a hospital, it's quite common to have IVs started. Most hospitals are going to probably have a nursing staff. They like to protect their job, so a lot of times they like to have that. Having said that, I had a student a few years ago at OHSU that my student was able to go in on a case where they used Definity, where students from OIT weren't allowed to go in because they don't do the training for IV setup. So it actually gave him an opportunity to go in and be part of that procedure. Okay, so the answer is it was recommended that techs get that because now we don't have to wait for nursing staff to, it's not going to delay the patient care if we can set it up ourselves. So if you're certified to do it, you're going to be in labs that you can. So the answer is really it depends on the lab, but I would not be surprised for a tech to do it. Will a student do it? Probably not. Okay, just like a student running a stress test on day one of clinicals, probably not. If it was me and I was running a lab, I'm not sure I would ever let a student do a treadmill stress test. Would I let them do a Definity? Sure. Because we have the 60 to 90-second window. And if you miss that window, which a student is likely to miss that window, you can't just redo the test. It's very expensive. So from a logistics standpoint, I would be surprised if someone has let you do that on a treadmill. Having said that, I've had students that have done it. So that would not be my comfort level, to be honest, but if they choose to do it. So you might get some exposure to that as a student. I think it's great. You learn a lot. Your resting echo really starts to come together when you start having to do stress tests because you have to move fast and you have to recognize when you see it and move on. You can't wait for a better picture. Okay. So it's great practice. That's why I think when you're scanning in lab, if every once in a while you test yourself to get the 4 standard echo views for stress echo and do it in a 2-minute time frame, that's going to help your quality of your resting images get better and better because you're now realizing you have to get the detail in a very short time. And if you drill yourself on it, that's where you begin to get better. And you'll also start to realize what you need to do for breathing technique to optimize that. Because you don't have time to wait for that perfect image of the heart to pop in view.
You just ran on a treadmill. Hold your breath now.
Yeah, and that's exactly right. And they will be breathing heavy and hard, and they will not be able to hold their breath very long. So you get what you can real quick. And you learn how to direct the patient to get them to do what you need them to do, because you'll also realize that when you make a command to the patient, it's going to take a couple of seconds to register and them to actually do it. So that 2 seconds of breathing, the heart's in a totally different location. If you tell them when you see a good image, it's too late. You have to anticipate where it's going to be in 2 seconds and tell them to hold their breath. And you do that by watching it come and go, come and go, come and go. Say, hold your breath, boom, there it is. And if it doesn't work, you do it again. But you have to be rapid on it and you have to have your finger on the trigger. Ready to go. Yeah. So the contrast, that's generally it. LVO, remember, is left ventricular opacification. That was the FDA's first cleared method of using contrast for the heart. And it was only in the heart. The rest of the body, we couldn't use contrast agents. Now we can in the liver, if you're looking at it outside of that, just generally speaking. Now there's Lumison and Definity are the 2 most common, but there are other brands out there with similar types of products to that. So, and as a rule, when should you be using contrast for wall motion?
When we can't see 2 segments.
Yep, exactly. Good. That's contrast. Specialized techniques we kind of touched on. So again, look at 3D/4D, look at, we'll touch lightly on strain imaging. You don't have to go, I've already explained way more detail than you probably even have on the registry, but it's a really cool technology and I would expect to see a big future in it. Kelsey?
I'm trying to find it in my notes and I can't seem to find it and I'm banging my head, but I'm just going to ask you. So when we do LVO, and we want to check the endocardial borders, like say we have just way too much brightness in the endocardium itself, like what was it again that helps us reduce that? Was it something with a pulse sequence scheme or something where you flash it?
Yeah, so if you're looking at perfusion
Right.
specifically, so we basically would let it fill up, and then there's a button that you're going to press on your system that basically triggers and ruptures all the bubbles at one time. And then it starts a timer, and then you start to see the filling coming back in, and you're going to see an absence of filling in that area that's blocked.
Which typically that's done with nuclear medicine, correct?
Yes.
Okay, but there was something specific about that pulsing thing. It was, what was the importance of that? It was something with harmonic imaging.
Well, it uses
I say it
harmonic
was,
imaging. So remember the tension on the walls is has to do with how, and it's the tension on the walls as the bubble's expanding. So it's in rarefaction, not compression. It's the rarefaction point where if that tension gets to a certain point, is going to rupture. I don't know if that's where you're going with it. I don't go into that much detail on it, but
okay.
yeah.
It's
But
also just
nuclear
kind of
medicine,
understanding it too, but
yeah,
I'll
nuke med
find
is
it.
definitely better at it. One cool thing that I found out from a friend of mine down in Oregon, he now works for a company called Barco. He does the Lunason. What they found was that with their mice testing that they did at OHSU, they had they found that when they cavitated those bubbles intentionally, it actually made the cells themselves, the cell membranes, more permeable to the medication temporarily. So it was actually a more efficient way of delivering medication to the site, which is kind of cool. So you might actually see the use of medicines being infused into these bubbles as a medicinal delivery system. Kind of cool. Okay, so that is contrast. Specialized techniques, all those various components that we have available for us in imaging. Aortic stenosis we talked about, regurgitation. Anything on aortic regurgitation?
Is that's the wide pulse pressure, right? I always get stenosis and regurgitation.
Yes, so narrow
Okay.
pulse pressures on stenosis and wide pulse pressures on
Okay.
regurgitation.
Once again, Ella helped me out with it last night. Let's go.
Good job, Ella.
Props to Ella.
Thanks.
She's there. You never know when you guys got your cameras turned off. You could be off partying somewhere for all I know.
We could be.
Could
Man,
be.
I wish.
At 10:30 in the morning.
But where else would you want to be except talking about the heart and echo? Okay, so mitral stenosis, mitral regurg.
Do we have any specific number on like when it becomes severe for mitral stenosis Vmax? Or is that not something that we've talked about really? Or
I think it
not
was
something that we
4.
have
Not that I'm going to
for
test
you?
on per se, but yes, there will be there are specific numbers on the charts.
Okay. Because I know aortic stenosis we talked about 4. Bam.
Yeah, mitral is going to be pretty much the same. So what? First
Okay.
of all, as we talk about stenosis and mitral valve, what's the most common way to measure the stenosis?
Measure the stenosis. Wouldn't that be
VTI.
from parasternal short axis?
Pressure halftime.
Time.
Pressure halftime. Yep. So it's a simple measurement. So you simply get your good 0 degrees, you put it through the usually apical 4 chamber, but it could be apical 2 chamber or 3 chamber. Straight line through there and get your highest velocity, measure the peak of the E and draw the slope down until it hits baseline. Make sure that you're getting the right caliper tool, being the pressure halftime tool and not the decel time tool.
If it has the
decel time
tool.
is going to tell you from the beginning to the baseline, pressure halftime is going to cut it in half, and that's going to give you your valve area. So what
do you do on the machines that don't have pressure halftime? What are we supposed to do? And the ones that don't do a slope, what am I supposed to do?
I would be really surprised clinically if the system didn't have that. It's if our systems don't, it's because somebody turned it off, to be honest. It's there, it just needs to be refound. Because even the old systems have that. That's a very old measurement.
Yeah, rooms 6 and 7, and maybe 8 and 3.
So 6
Not
and
so
7, that's
good.
not the logic 9, is it?
Those are
If it's-
Philips, aren't they?
5500 should do it.
I don't know.
It's the P5.
The P5 should have it. Somebody probably turned it off because, sorry, soapbox. They sent in a general imaging tech to set those up. They know nothing about cardiac. And that is evident in our cardiac quality of those systems. Does it do cardiac? Yes. But not well. No, the reality is they'll have that measurement available. Sometimes they hide measurements and stuff because we don't want a whole bunch of things on there, but somebody didn't guide them very well when they set it up initially.
So what do we do? Because it's not there in 6 and 7.
Okay, so 6 and 7 are both P5s, right? And you could ask Tyler what he will grade you on, but if you don't have a pressure halftime tool, what I'm more interested in from your perspective in lab is, are you measuring it accurately? Like, are you placing the calipers in the right spot? So if you have a decel time, that's great. If you have something that can show me the peak of the E, the mark at the baseline, and the dotted line in between, that will at least tell me that you're measuring it accurately, even though it's not the right tool. Yeah, go ahead, Mike.
So this is my mindset for the back room, is just working on my windows, working on proper placements, not really caring about measurements too much, whether I have it or not, if I don't have the tools for it. Is that a good mindset to have, or is that a bad mindset to have?
I think that's a reasonable mindset. I'll say that. Because yeah, I mean, why waste your time looking for something that's not displayed?
Okay.
Now, having said that, there is some things that you can do to go find additional measurements. So if you're in the measurement tools, the toggle, that's that 4-button toggle on the side, if you toggle up and down, it might give you additional measurement options that are not displayed.
I just don't want to spend half my study looking for one measurement that's not there, but I can just
I get it.
caliper.
I mean, really, from a grading standpoint, you should check with Tyler to see what he's going to grade you on, and I think that would be a reasonable expectation. Just grab something that at least approximates that.
Yeah. So yesterday, Kathleen and I were in room 6, and I know it's going to transfer to my worksheet, but as long as I recorrect it, I just used A duration because it gives a time for decel time.
Right. Now, yeah, if you're doing that, so the pressure
Iteration is
halftime
this way.
Still a time measurement if you're trying to get decel time.
Yeah, it's a time-based measurement. Those rooms are tough.
So
Seven's
Scott, is
got a
that
decel
something?
time.
Oh, sorry.
So
No, you're fine. 7's got a decel time. It's just in with the EA when you're doing pulsed.
okay.
It automatically does the decel time when you click the E wave.
That's right.
Okay.
I think
Yeah,
I remember talking about that with Kathleen.
Sometimes it's a weird spot. Go
Is
ahead,
that
Nancy.
something you're able to turn back on? Or do you need a tech to do that?
Yeah, usually we can go in and do that. That's not usually, doesn't require a password. Usually it's internal system things that, because even an application specialist doesn't need special passwords to do stuff like that. You just need to go find it and reactivate it.
Is that something you're willing to do for us? Maybe, possibly.
Yeah, if we can sit down and do it. I think I've actually done it in the past, but what happens is the service people come in and service it, and they don't resave the presets. So then we have to do it again, but which is fine. We can do it. But yeah, we can take a look at it and see. Yeah, even the 5500s, I've actually gone into those, and there's a whole ton of measurements that they've hidden in there. And I don't know who set those systems up, but it was not a good job, in my opinion. Okay, valve replacements, devices. So tell me the differences between the different devices that can be implanted into the heart.
Well, the main two are mechanical or bio, and whether it's we can do native valve replacement, but that's only from like pulmonary to aortic, and that's not very. Is that not very common, from my understanding? Not
It,
super.
it's more common in pediatrics.
Okay. Yeah, and then mechanical lasts for a long duration. Those are the ones you have to take blood thinners on, though, right? So
Yes,
that's the sucky part of those. So
that is the
and then we have bio valves, which you don't have to take blood thinners, but you have to get them replaced every once in a while. So it's
yeah, you replace them more frequently. Now, I wouldn't say you don't take blood thinners on those. It's just less of a dose or less likely to have to take them, and you do take them initially always.
yeah,
But you might be able to wean off of them, whereas mechanical valve you can't.
yeah. And you told us that was a huge lifestyle change that is very annoying. So that's why some people go for the bioprosthesis instead of the mechanical, even though they know they're going to have it replaced with another cardiac surgery.
Yep. I always say that you can tell the people with cardiac surgeries, and especially those that are diabetic smokers, have what I call the zipper chest. So they got that big scar down the middle. Now, if they actually put a zipper in there, might not be as bad, but that ain't happening.
Yeah.
They have to go in, they have to unwire it. Okay, I don't know. All right, TAVRs. So where do
That's
they go?
going through the leg, I believe, to go and replace a valve.
So three possible ways to approach it. It could go in through the leg. It could go in through the chest wall directly through the LV, or it
Yeah.
could come up through transjugular area.
Okay. Yeah. The going through the heart wall one looks so weird. Like just hey, here we go. Whoop.
I know that's
Just
pretty.
straight through, guys.
So just to give you perspective, so back in the day, so remember I told you about amniocentesis. So they take samples of the baby's fluid when the baby's developing, and they do testing and stuff on that to see if they're likely to have like Down syndrome and things like that. So what do you think they did before they had ultrasound guidance for those kinds of things? Because we go in and we guide them into a good pocket of fluid so it doesn't do any damage to anything.
Yes.
They poke. And they, when they do like an IV, so if you do like the vaccine, for example, when they poke into your arm, they're supposed to pull back first to see if they're getting blood, because that tells them if they're in a vessel. Okay, you don't want to be in a vessel if it's an IM. So they're supposed to pull back and see if there's any fluid and stuff. So back in the day, they'd sort of do the whole watermelon tap 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 tap, look for a hollow spot, poke it in. They
Do
drop
they use
back.
a stethoscope for that too?
They may or may not. But the reality is, they would poke stuff. They would poke through baby heads. They would poke through the limbs, through the body. Guess what happens when they're doing a pericardiocentesis? Same thing. So it's a pocket of fluid around the heart. They tap it in, and again, they're trying to go for that hollow spot. Using ultrasound guidance is way more effective, but they had to tap it in back before ultrasound was a thing, and they had to try to draw back. And if they got a whole bunch of blood in there, then obviously they went too far and they stuck it into the heart. And they got to draw back to where they're just getting clear fluid or whatever the fluid content is. So back in the days before ultrasound, yeah. Nowadays, they've got some amazing technology. We just talked to the vendor yesterday that does the butterfly ultrasound. So they're $2,000 transducers that are not piezoelectric crystals. They are the chip based that I told you about before. They are corded, so they don't have cordless. But now you can use those in an ER, and they can do those procedures and stuff from there very quickly and see the pockets of fluid and see the needle where it's placed and stuff like that. So ultrasound has changed the game in a lot of ways for a lot of things.
Do you have one butterfly to see it?
I don't, but we're considering buying some.
Ooh.
Okay.
So they won't replace our big systems, but we're looking at how we would use it. At the very least, I would like to use it for advertising the program. So when we go out to like high schools and stuff, we can kind of show people without having to bring a big machine. And then likewise, there's the potential we could actually either have the students buy their own, that's expensive, or have them lent out or leased out to the student for the quarter to take and scan. And we can actually, because it's uploaded to a cloud-based web server, we can actually go in and evaluate some studies in that. I think it's great for hand-eye coordination and learning how to do that, because the more hands-on time you have with the transducer, the better. We can guide you. There's actually teleconferencing stuff you could do now, so that we could actually walk you through something from a distance if we had to. That would be difficult for a lab, because then it's a lot less controlled situation. You're not going to have good beds and stuff to scan on and stuff at home, obviously. So there's pluses and minuses. So we're trying to evaluate if that's something worth having. The thing is, it's a $2,000 transducer. It does linear, curvilinear. I don't think it does curvilinear, but it has a vector format, and it does cardiac. It actually does 3D slices, which is kind of cool. It does biplane imaging, which takes two planes at one time, 90 degrees to each other. So there's some really cool concepts it has because of that chip technology instead of piezoelectric crystal. It's aluminum case. Anyway, it's pretty cool concept, but it's $2,000 to buy. Up front, it connects us to either an iPhone or an Android device. It goes onto the cloud, which is great. But there's also you have to have a subscription yearly. So it's an annual subscription that you have to pay for. So the cost isn't totally cheap, but way better than buying a new system. So medical residents and stuff now are actually required to get those as part of their programs now. You'll find them pretty much in all the ERs and stuff nowadays. But it's not going to replace what we do. In fact, it can't even do color and spectral Doppler at the same time. While it can do each of those, it can't do them together yet.
Yeah, Scott, just to touch on that, one of the hospitals in Portland makes the doctors do like one of the handheld echoes before they order an echo in the ER, because they're going down there so much.
Yeah, I mean, it's a game changer. So when I was doing my master's degree and looking at health leadership, we looked at what we call disruptive technologies. And a disruptive technology is finding something that it thinks way outside the box and significantly reduces the cost of medicine, while increasing the speed of receiving it and the overall quality for the patient. So that's what I would consider a disruptive technology in ultrasound world for sure.
How is that disruptive? It sounds good to me.
It does, but if you have to call down an echo tech every time that's gone home in the middle of the night, and you have to call them in, and it takes them 30 minutes to get there, or 20 minutes, or whatever it is, then they got to get the equipment and they got to get to the room. They could have done it in 5 minutes and known if there's any like imminent emergency stuff that has to be done versus doing a regular echo.
Sounds like those techs are being used and abused at one point.
Oh yeah, no, we all get that way. Yeah, I think, Kelsey, correct me if I'm wrong, but I think the least abused techs in ultrasound are probably vascular techs as far as Paul goes. General techs
Probably, yeah.
Front of it. Echo techs, they'll get called out decently. But vascular techs, there's not as many truly emergent procedures that you got to go in for. And usually the vascular labs will pass it off to the general labs to do like DVT studies in the middle of the night. That's how inland imaging works. The vascular lab passes those off, carotids and venous exams at night, to go to the general tech.
It was actually opposite at the hospital I was at. It was vascular in general, where general was obviously the most abused, but vascular got called in way more than echo, just because the echo techs had really good cardiologists above them, though. They rarely got called in. But Saturdays, though, they were pretty much there all day.
Really? Yeah. Yeah, I mean, if there's a cardiac emergency, you don't have time to do an echo anyway. You got to get other stuff done. So even some of the vascular studies, I would often get called in the middle of the night to do a venous exam. I was actually on the night shift, but what was ironic is they were usually treating the patient before I even did the exam, because the cost of treatment was less than, if they waited, there's a higher risk of something happening. And the cost of treatment was low, so they would just treat them, and then they'd call somebody in the middle of the night to scan it. It's like, you could have waited till 6 a.m. because they're already being treated. But some days, my favorite phrase is, I just work here.
That also, I don't know, it also could have just been that way for me because they had too many complications with general techs miscalling thrombus in certain segments.
From a quality standpoint, I 100% agree with that. I think they should be calling the vascular techs out for vascular studies. As I mentioned with general tech scanning fetal hearts and stuff, and they know just enough to get themselves into a lot of trouble. So I think there's a lot of misdiagnoses. I think you're better to call the people that are specialized in that. But that's why I'm going into hospital admin, so I can change the paradigm. All right, so prosthetic valves. So yeah, blood thinners. What kind of bad things happen with valve replacements and devices?
Dehiscence.
Dehiscence, that's a great term. What does that mean? What do you see on an echo?
Rocking.
Rocking motion. If it's rocking, if the structure is moving back and forth like this, that's a bad sign. You should be looking for a hole.
Valve replacement mismatch.
Yep, mismatch. What about things attached to the valves?
Vegetations.
Anus.
Thrombus.
Yes.
Abscess.
Yep, good.
All these fun S's.
What was that one, Mike?
All the fun S's.
SSSs, yep. That's true. So yeah, look for things hanging off of it. Is it easier or harder to scan than a native valve?
Typically harder.
Harder.
Yes, it is harder. However, I will say that when you have a severely calcified valve, they are pretty hard to scan too. And same concept, you need to look around at different windows, different perspectives. The window is 99% of your echo. Good. And sometimes so which valve is harder to see stuff on either side of it compared to the other as far as aortic versus mitral?
Mitral because it's obscured by the aortic?
Yeah, it is partly obscured by the aortic, but the mitral valve itself, you get that section near the posterior leaflet that you don't see well from a peristernal perspective, and you don't see it from an apical perspective. So it's the harder one to see behind. So if you had to, you could do TEE to see from behind it directly.
Is that when we would use like a para-apical view that Tammy was talking about? Kind of just try and work through it, see if we can't get something.
You can, but the para-apical views are most helpful for right heart stuff. So tricuspid valve, tricuspid regurgitation, looking at the right ventricle. So from a classic perspective, and I used to do this before it was labeled as a thing, as a para-apical, but I would typically go more lateral to put the LV as a window to see the right heart. So if you want to see the chamber, you go lateral. If you want to see the best Doppler angle, you go medial. You basically go halfway between an apical view and a peristernal view. And that gets you the best angle for tricuspids. So Doppler, I'm going medial. If it's seeing the 2D, I'm going lateral and or subclavian. Good. CAD. So you got some suspected CAD things going on. Tell me about patients' histories and things that they might present with if they've got CAD.
Dyspnea upon exertion, family history of heart problems, overweight sometimes due to plaque buildup is a big sign too. We might see plaque buildup at the origin of the coronary artery, but that's better seen in MRI and CT.
The Framingham factors.
Oh yeah, that's the family stuff.
Yep. So what again is a significant family history?
Immediate family, sister, brother, mom, dad.
Okay, so the closer relative they are, the more likelihood. But what about timing of that heart attack in their age?
Is it below 40 or below 35? I want to say. somewhere in
Yeah, I mean, I would say definitely something below 40 would definitely be sending up red flags to me. If they're like my age, like 47, could be either way.
Okay.
Diabetics have a higher likelihood.
Mm.
So again, just from a statistic standpoint, the first heart attack that a female will typically first have their first heart attack would be, I think it's 72, and the first male would be 62. And if they're diabetic, a female will be 52 and a male will be 52. Diabetics have a significant risk increase.
Are you talking
That's
about like what's
part of
their,
proof.
are you talking
What's
about like what's their probability of having a heart attack within the certain amount of years, the 10-year
Yeah.
mark?
So if I got a patient that's, if I got a male patient 65, for example, that has their first heart attack, that would not be considered a significant family history. If I got a female that's 75, no. If I got a female that's, 62, it might not be a significant family history, but it's definitely going to put up some flags as far as diabetes and atherosclerotic buildup. Same thing with a 52, just over 52 years old for male. And then you always have that gray area underneath that. So if we're between like 40 to 52, I am going to be thinking more congenital type stuff, but if it's under like 40, for sure. Those are the ones that are like, yeah, you definitely got something going on. I don't know if I told you this case, but probably because we haven't got to the section yet, but I had a patient come in. There's a husband and wife that came in. My female colleagues scanned the wife. I scanned the guy. Separately in different rooms, we're asking them their historical questions, and both of us, because it had a family on both of their things, it had family history of heart disease, of hypertrophic cardiomyopathy. And so we're like, okay, so tell us about the family history and that. And it was tough. Their son had died not even a month earlier, and they were both being screened for hypertrophic obstructive cardiomyopathy. And so it was like, that's a rude awakening, when you go in there and you sort of expect when people have a family history of heart disease, it's somebody that died a long time ago, or usually that's an older person, that was older than them. But when it's their kid, that's tough. So both of my colleague and I were definitely sideswiped by that one. It's like, dang, I'm so sorry. And then you have to do the whole exam. You're there with them for like an hour. That's rough.
So if we see like significant family history, is that when we're looking for like the different analogous origins of the like coronary arteries too? Because it's not always atherosclerosis and that kind of thing.
It could be, but the doctor's usually going to be looking for something in particular. So the example I just shared, we were actually looking for hypertrophic cardiomyopathy. We're looking for thick walls.
Okay, and it's pretty well documented what you want to look for specifically in that case.
Yeah, at least it will be fairly narrowed down already. Usually if it's more of a congenital thing, you're already, you'll kind of know that. But in a typical adult lab, you're not going to be doing a lot of congenital stuff. They would probably send that to an adult congenital lab if there is one around, or a pediatric lab. And typically those severe pediatric things, they'll already know about it because that patient would have had already a bunch of surgeries and a bunch of tests. They typically won't live to the age of 50 or 60 if they've got major anomalies. There's a few that surprise us. So that's why you never totally rule anything out.
So Scott, according to the midterm exam, it's kind of like a lot of information and it's a lot of detailed information. How detailed is test? Is it a lot of pictures there? Can we, if it's possible,
yeah, not gonna be a lot of pictures. Mostly I just ask questions. There might be some pictures. So I think what we've talked about in each of these sections, I'll usually hit up the major stuff in each section, and just keeping in mind from my perspective as I create a test, if I have to do it over multiple chapters, I'm not going to get super nitpicky on, one thing that was mentioned once in a book somewhere. I might throw the odd one of those out there, but for the most part, it's going to be the take home message kind of stuff. It's going to be the big stuff. Because remember, if I've got a 50 question quiz and I've got 10 chapters to cover, that's 5 questions per chapter. I'm not going to waste my time on nitpicky things.
So we're gonna see kind of the same depth we've been seeing with the 10 questions.
Yep.
All right. Well, in that case, woohoo! I might score well. Let's go.
Yeah. Yeah, I mean, it's Rachel was telling me about one program, actually the Duke program. So she went down to evaluate it for accreditation, and she said that they had in their first quarter or whatever, they had like a midterm exam was all they had in the final. The midterm exam was like 700 questions, but they'd never had any quizzes before that. So they went into it cold turkey, 700 questions.
Oh my gosh.
Yeah.
That's mean.
No.
Yeah, because you don't at that point you don't even know how your teacher asks a question.
Is it like 7 hours exam?
I don't remember what it was. They had to have like 3 or
Word.
4, but it's a different program. That program requires that you have a bachelor's degree to come in. Your GPA has to be like a 3.5 minimum. There's just different requirements when you come into the program. I think it's a 1-year program.
We get a lunch break with that too.
Yeah, dang. Yeah, I took the MCAT exam, which is a medical school test, and that's like an all-day affair. You'll have like a 3 hours of testing, and then you get like an hour break, and then you go for another 3 hours of testing. Good times. The biggest interviews I had for a job or it was actually for a school, is the PA program I got interviewed for in St. Louis. It was 3 days of interviews, and so you actually interviewed one-on-one with multiple people, from doctors to techs to faculty. It was interesting. Every other interview after that's been cakewalk comparatively. So it goes back to my point of doing a stress echo to help improve your resting echo. Sometimes when you expose yourself to much more difficult things, the other things don't seem so bad anymore.
Will we get to do hands-on during this clinical, or probably not?
Yes, you will. It depends on the site. Some sites, a busier site tends to give the student less scanning time. A slow site, you'll typically get quite a bit of scanning time. So being in a site that's slow isn't such a bad thing at this point. You may not see and do everything, but you'll get a lot more hands-on. So most of my sites that we've worked with, they're pretty good at giving the student at least some time, but you're not going to have, what you want to capitalize on this summer is before the clinical, you want to capitalize on scanning every moment you can the volunteers that come in. And if the schedule is light, which typically does happen, it's just like a real patient clinic, patients no show and stuff like that. And you don't always have a full schedule. So if you want to recruit people to come in, that would be super, super helpful.
I'm stealing my roommate for sure.
Yep. No, the more you can keep your hands on the transducer, the better. Because honestly, you're going to scan a lot right there in that lab. You're going to go to clinical and you're going to scan maybe 10 minutes per patient. So you'll get like less than an hour of scan time for the whole day, but you're going to be there all day. And then you're going to have like 3 weeks off, and then you'll come back in late September, and you're either going to be in clinical or in lab, and that's the next time you scan. So you're gonna actually lose a chunk of information and some of that training. It will come back, but it's going to feel rusty that first couple days back, for sure.
Ooh, that kind of sucks.
It does. I really wish it wasn't structured that way. In my perfect world, I would actually have us do clinical full-time starting in September and go all the way through June. I think that'd be a better way to go. You'll get more hands-on scanning. You'll get your Christmas break, which is a couple, 2 to 3 weeks off. You'll get another week off between spring break, but I think it would be better. That's just that again is one of those processes that just takes forever to get approved and changed. But
right.
And we would have to restructure everything as well, because if you made that shift now, there's classes that you were normally at in the fall quarter that we'd have to move into a different quarter. But that would be my long-term plan.
I gotcha.
Unfortunately, it won't affect you guys. Sorry.
Some unfortunate will be graduated and working. That's good.
That's true. You're getting a paycheck, and you can maybe get students in the future and be nice to them because you'll remember what it was like, right? It always
No,
frustrates
trial
me
by
when
fire.
yeah, it frustrates me so much when techs get out there and they're working with students and they express, so much how they hate working with students, and that's like, so you don't feel welcome by some techs, and it's just, I hate it when people have that attitude. It's like, you were students once too.
That's how my Tri-Cities clinic was. They did not want a student and made it very clear.
Yeah, that's so unfortunate. I mean, they're burning themselves in a way, because when they need to hire people, if you were a student at that or had colleagues that were there, you're going to remember that and how they treated people.
Yeah, I actually started training one of the previous vascular students that I think was in Sarah's class.
Okay.
And it was so fun because I was leaving. So they're like, well, you only get to be with Kelsey for 2 weeks, but it just brings back that joy and that love and what made you do the program or do the field that you're in.
Yes, but with less stress on your part.
You push it off and you're like, okay, I'll come check on you in a minute.
Yeah, I remember what that was like. Have fun. It's good. No, I highly suggest that at some point in your career, once you get good at what you're doing, do something to give back to the community of Echo. I think it's always good. It keeps you grounded and keeps you well established in what you do. All right, I guess we out of time. So Thursday, 6 to midnight, the test is open.
We don't have class on Thursday, do we, with you?
Do not.
Just
no
the
class.
midterm? Okay.
And just to remember, we don't have class tomorrow either because it's faculty development day.
I did have one last question.
Yes.
There was something that stumped me on a quiz, and I remember it had something to do with bowing of the interatrial septum.
Okay.
So with MR, you'll have evidence of pulmonary hypertension, and you'll have a dilated LV and LA, which is what causes the bowing. But is it a specific bowing or is it just any bowing?
So most of the time it's going to be, because it's going back into the LA primarily, it's going to be a higher pressure in the LA and higher volume, which pushes even further into the right side than normal. But once the hearts become what we call cyanotic and it goes the other direction, especially if you have a shunt, well, you will have a shunt at that point, but that's when the right heart pressures exceed the left heart pressures, and then it will push from right to left. When we do a bubble study, agitated saline study, we have them do a Valsalva maneuver. So we have them bear down. We're actually increasing the right heart pressures over the left heart pressures. That's why we see bubbles push from the right to the left. But that's only momentarily with a technique. But if it's doing that without that technique, that person's got problems.
So in MR, depending on like where we are in it, we could see the septum bowing either to the left or to the right. We could see it in both.
Yeah, so it's typically going to push from the left towards the right. If it's a billowing septum, what you're going to be concerned about there, you might not have like a big regurg, but you will be concerned about shunting going across and reopening the PFO.
Yeah. I don't like to see this with my septums. No thanks.
Yeah. True.
Thank you.
All right. Good luck. You guys got this.
Thank you.
Thank you very much.
Thank you. Thank you.
Thank you.